This is Paul's case study overview by Riley Crandall, Lauren DePew, Nico Kelley, and Gia Storey.
Okay, so there were goals made for Paul based on the biomechanical frame of reference, which focuses on the integrity of body structures and factors such as endurance and strength that impact a client's participation in meaningful occupations. So there were two long-term goals. The first one was focused on simple meal prep and having him do that independently and safely, and that would be completed within 4 weeks. And the second one was completing dressing tasks independently with adaptive measures, and that would be completed hopefully within 6 weeks. So the short-term goals, there were two building up to both of the long-term goals. So we have client will collect ingredients for meal prep with adaptive equipment in the kitchen within 2 sessions. And then within 3 sessions, the client will prepare a 2-step meal seated with setup assistance. And then the client will maintain total knee replacement precautions during seated simulated dressing with 100% accuracy within 2 weeks. And then within 3 weeks, the client will maintain standing balance for 5 minutes using a front-wheeled walker with lower body dressing tasks with standby assists. So, oops, sorry. The goals for Paul were focused on dressing and meal prep tasks, and this is relevant to the client's context because he was independent in all ADL and IADL tasks prior to his total knee replacement. And the biomechanical frame of reference was chosen to support these goals because the goals focused on improving range of motion, standing tolerance, endurance, and strength post-total knee replacement. And this frame of reference focuses on how the integrity of body structures and factors, such as endurance and strength, impact participation. Other goals that could be prioritized could include functional community mobility. Paul stated that he enjoyed going grocery shopping prior to the surgery. Goals on education and training for safe community mobility would be beneficial to allowing Paul to engage in meaningful occupations to him.
As for Paul's intervention plan, this intervention plan consisted of the start of the session, beginning with education and training on safety and pain management. The first intervention, having Paul sit at the edge of the bed with the front-wheeled walker for balance and weight-bearing precautions, and complete sit-to-stand transfers using therapy bands to simulate lower body dressing. Intervention number 2 consists of dynamic standing in ADL therapy kitchen, using the counter for support with bilateral upper extremity reaching, retrieving, placing on counter, and replacing various size, shapes, and weighted food items from cupboards. And this will help address his standing activity tolerance with dynamic reaching. And lastly, the third intervention consists of standing with the front-wheeled walker and complete gathering clothes off the floor using a reacher, folding it, and placing it in the correct dresser or closet. So were these interventions appropriate for the client and the frame of reference? All of these interventions definitely addressed the biomechanical frame of reference. All activities addressed endurance, range of motion, strengthening, and safe movement post-surgery. Additionally, these interventions were evidence-based, as evidence-based research was provided to support all of them. And the research also supports the importance of balance training post total knee replacement and total knee arthroplasty, which was a primary focus for his intervention activities. So all 3 activities were also described to take 15 minutes within a 10-minute educational period at the start of the session and a 5-minute wrap-up at the end of the session. So all follow the 60-minute treatment plan and is reasonable for that time frame. Did plans reflect the use of occupations that were meaningful and purposeful to the client? Both of these interventions are meaningful and purposeful to the client. The first intervention is purposeful as dressing activities can help him achieve greater independence at his age in dressing. And additionally, the second intervention is also purposeful as it is a preparatory task to perform meal prep activities, which he does desire to do. He does enjoy trying new foods and meal prepping simple meals. Some additional interventions that we would suggest would be an additional goal of functional community mobility. And this additional intervention could be training on grocery shopping simulated tasks, which include reaching and managing his walker and also dynamic balance.
So there were some noted differences between the original 60-minute treatment plan and the treatment video. So the intervention plan focused on standing balance using front wheel walker during lower body dressing, and then also collecting ingredients for meal preparation in the kitchen. In the video, they chose the short-term goal. Client will maintain total knee replacement precautions during seated simulated dressing with 100% accuracy within 2 weeks. They addressed seating lower body dressing by donning socks with a sock aid, donning shoes with a shoe horn, and donning pants without an assistive device, but they did not address any of the standing balance or gathering meal prep items. The intervention tied into the biomechanical frame of reference, as so in the video. This focused on strength and endurance needed to support balance and decrease a fall risk. In the video, they completed lower body dressing in a seated position, which supports seated balance. However, the evidence that was provided focused on standing balance. The selected interventions were clearly shown in the video. This began with modeling on how to use the sock aid, as well as providing caregiver education. And there were no graded options specifically stated in the video. However, one thing that we did note was when Paul was kind of scooching to the edge of bed, the OT had his sister refrain from helping him, making him complete the task independently, which made it more challenging for him. However, if Paul did need the task graded down, the sister could assist with moving him to edge of bed. The contextual factors were clearly addressed in the video. Some supporting ones that we noted was the family caregiver support. Paul has very high motivation and he has good vision and hearing. Some inhibiting factors were he required support for lower body dressing, he has pain, and he has some fatigue. And then some kind of recommended changes. We said we would suggest incorporating elements from the original 60-minute treatment plan to kind of better align with the intervention and the identified goals. This can include adding like a brief standing balance or integrating like a functional task such as gathering simulated meal preparation items, just to kind of support that planned ADL focus. But by consistently reinforcing the total knee precautions during the seated tasks as demonstrated in the video, this would further support the client education, ensure safety throughout the intervention.
The plan communication regarding Paul's case study was client-centered, goal-oriented, justified, ethical, professional, and supportive. The plan that has been created for Paul has been client-centered. Paul's goals to regain independence, reduce his fall risk, and return to his caregiver responsibilities for his wife were all integrated into his plan. The client's factors that inhibit or support performance were all taken into consideration, such as how the client values his wife and children. In addition, it considers activities that the client enjoys and how it affects occupational participation, such as reading newspapers, watching sports, going to concerts and lectures, preparing meals, or even trying new foods. The goals created for the client reflect the needs and values of the client. There was written communication provided that was clear and professional for each part of Paul's case study. Written communication regarding the client, every part of the plan was professional and ethical, as well as detailed and justified. The client's occupational profile was detailed. The frame of reference that was chosen to support the client's care was researched. The goals created for Paul were concise and client-centered. His interventions were specific, and the discharge plan was professional. There were some notes included to further communication and documentation that was helpful to our group. There was a handoff communication email that was created to communicate assessment results regarding referral for the client, which is helpful for interprofessional disciplines. There was no missing information or items that may have been overlooked regarding Paul. All contextual factors were considered and implemented through documentation, implementation of treatment interventions, and the discharge of the client. Our group appreciates the collective effort that was taken to complete all of the parts of Paul's case study. There would have been a few minor adjustments that would have been made if our group would have had the opportunity to complete all of the parts of the case study independently. We would have taken a different approach personally to filming the treatment intervention for Paul. We would have begun the treatment session at the beginning of the recording to simulate a real therapy session environment. We appreciated that there was a brief occupational profile description of the client, but we would have just personally gone about it in a different way and organized our recorded session differently. Our group would have just started recording the video with introducing ourselves as student occupational therapists and just starting whatever treatment intervention was planned with Paul during that session, rather than starting with a brief overview of Paul's care. Additionally, our group would have focused the client's goals pertaining to his right knee and functional activities that he enjoys doing to help reintegrate him into social participation and engagement in meaningful activities.
Upon discharge, we made a plan for Paul's caregiver training, a home exercise program, and recommendations for discharge. So Paul has a child that lives nearby and a neighbor. So both of them should receive education on safe mobility and transfer techniques so they can assist him appropriately during his recovery. They should also be taught how to support and reinforce his own home exercise program. Paul should continue outpatient or in-home therapy services that focus on pain management, range of motion, and edema control. Paul should be educated in pain and edema management strategies that he can perform at home. He should continue to use a front wheel walker for functional mobility, and further education should be provided on performing tub bench transfers to ensure safe and independent bathing. To further maximize his safety and independence, a hospital bed could be rented to support Paul in performing safer sit-to-stand transfers by allowing him to adjust the height of the bed as needed. It might be a little more comfortable for him, as you can adjust the feet and the legs positioning as well, but that can also just be an option to speak to the family about. So then, in terms of an HEP, or a home exercise program, we chose to include one that is specific for clients that have undergone a total knee replacement. And this exercise program would allow Paul to focus on limiting pain and swelling in his knee, along with improving range of motion and strength, endurance, and balance that would in turn increase his independence and functional mobility to complete his ADLs and IADLs and increase independence with transfers for a better quality of life. So we have the home exercise program in a reference on this slide. It's a couple pages long, so it would be a little hard to link right directly into the PowerPoint. And then in terms of referrals, Paul is currently experiencing impaired mobility, pain, limited weight bearing, and reduced activity tolerance after his total knee replacement, making him unable to safely resume caregiving for his wife. A home caregiver would provide essential help with ADLs, mobility, and household tasks, supporting Paul's recovery while ensuring his wife's safety as well. This assistance would also reduce fall risk and help Paul follow his weight-bearing precautions. Additionally, a social worker is also recommended to coordinate the increased level of care needed for both Paul and his wife. Given Paul's need for 24/7 supervision and his wife's ongoing mental health needs, a social worker can arrange services such as home health, transportation, meal support, and long-term planning. This ensures a safe discharge home and helps both individuals maintain their well-being throughout Paul's recovery.